discuss about the rational use of laboratory investigations. These are things. And these are the general biochemistry tests we provide. I want to insist on certain things. Timely collection and sending to the lab on time. I want to tell that, like, in the clinic, a doctor is ordering a fasting blood sugar. So it's our lab responsibility to give a correct result. Then only the doctor can initiate a correct anti-hyperglycemic treatment, isn't it? So if the fasting time is prolonged, if you take it in a wrong time, and if you keep it for a long time, I know there are preservatives in the sugar tube, I know that, but still it is recommended to analyze as soon as possible, because we don't know, although there are preservatives, how much these red cells are eating the sugar, we don't know. So that is one of my concern: timely collection and sending the specimen to the lab on time. And issues with night on call samples. You all are aware of the ministry circular, isn't it? This is the ministry circular. They have clearly stated these are the list of investigation that can be done after our sample. Okay, I can read it for you. We are type 3A hospital. Okay, so we can do full blood count, packed cell volume, platelet count, PTNR, and the CSF, creatinine, electrolyte, SGOT, HPT, troponin, amylase. Okay, bilirubin total, bilirubin direct, blood sugar, CRP, serum calcium, UFR. Okay, ABTT. Those are the list of tests. This is the ministry's message to you all. Like, you can order this test only, and you can clearly see there are no profiles. Okay, there's no profiles, no liver function test, no renal function test. Okay, and when I came there was already an intern batch. So now you all are starting now, and I have given you the message. Okay, so in the future, if I check any night on call investigation, and if I happen to find any profile, I'll ask you. Okay, why? What is the rationale for ordering that? Okay. So that is the message. And write the individual test. Any individual test, we are definitely going to do it for you, for the patient. Okay. Some performance statistic. Like, when I came to the hospital, I asked my chief MLT to produce me the performance statistics. That means the last 1 year, how many tests we have done so far, and all the basic parameters were fine. But I was surprised to see this particular investigation, CRP. Okay, and this I just roughly put cost per test is 1,000, but you're all aware that outside hospital, outside laboratory investigations are higher than that. Okay, so number of tests per year, I was surprised to see 20,000, and that was the last year one. And this year, when I see the pattern of CRP, like, I know how many tests done per day, because hospital statistics are daily produced to us. So I think this year it will come 25,000, I think. So if you roughly multiply and see the cost, and I feel like for a base hospital and the number of patients we are currently treating, this is too much. Okay, and we are not going to say no to any CRP you are writing, but I will check. I'll ask the question: what is the rationale? Okay, and this is the audit they have done. It is available in the website. In UK, in Black Country Pathology Services, they have done this study, clinical appropriateness of C-reactive protein request. Okay, and they have found surprisingly like how many unwanted CRPs were done. Okay, Royal College of Pathologists suggest that CRP testing minimum retesting interval is 24 hours, but still the people who did this study, they felt that is also more than that, and they set up the interval of 48 hours. Okay, 48 hours. So in their hospital, what they can do is, if from the ward, like May 1st, one CRP request is coming, and like, if the doctor writes the same CRP request on May 2nd morning, the system automatically vet the test. Like, it will cut it down. Like, it will send the auto message to the doctor: you have ordered this test yesterday, still the 48 hours not passed. So do you want to do the test? If you want to do the test, discuss with the lab. Okay, so they did that, and they have reduced so many unwanted CRPs, and they produce this paper, and they mention how much pounds they saved, because the study is done in UK. So they saved millions of pounds by only restricting the CRP test. Okay, so what is the half-life of CRP? The other message, it's 19 hours. Okay, why repeat it in the morning and evening? Okay, so this message, this study, they have done it in the medical surgical ward. Okay, this is not applicable to the critical care unit and a pediatric unit. Okay? I want to convey that message, and don't take the wrong information. This madam is against CRP. No, I am not. CRP is a good investigation, but you have to use it rationally. Okay, and then these are the special investigation we provide in our lab. um, and I have found statistics on clinic requests, the doctors who are writing the clinic request, and I have found that 70% of the thyroid profile had a T3 test ordering, and 100% of the T3 results were normal. Okay, and I wonder whether it is really necessary. Okay, because if you want to screen someone is really hypothyroid, TSH is not, it's enough, and if you want, you can order T4, but why T3, isn't it? And the ministry circular also state that the category of investigation and the category of doctors who can order the test, and thyroid function test is actually a consultant order test. So I want to convey this message to you all. And these are the urine stool investigations. Body fluids we can perform, and investigations to be sent outside. Okay, and because we are a base hospital, so we can't have all the sophisticated investigations, all the hi-fi hormones in our lab. So the it is recommended to send it to a closer, bigger hospital to do that. So if you want, if your consultant asks you all to arrange for a special hormone like FSH-LH, you can contact the lab, and we can send it to a closer hospital like Teaching Hospital Batticalow. But there are special forms to fill with the proper history and proper consultant seal and signature. So they will check whether you all have filled it properly, and they will definitely do that. If you write your WhatsApp number, and if you mention that if the results are abnormal, please send us a WhatsApp report, they will do it. Okay, so I have seen it happening, so make use of that service. And MRI, I know it's a bit tricky, like we have to send a sample from here to an ambulance, and we have to collect the report. The delay is a bit of a concern, but some investigation, like for example, if you want to do parathyroid hormone, we don't have it in Teaching Hospital Batticalow, so we have to request MRI. You can do the test, and they have this special form to fill. Just fill it and get the authorization, and the test will be done. That is very simple. Okay, so very important hormones, they do ACTH. Okay, so some are not available even at Batticalow. So a little bit about sample collection, and I know you all are very expert in this area, especially nursing officers. You all are very experienced. I don't need to tell more information, but I'm just giving you the reminder message. Okay, so this graph, this circle, you all are aware of it. When you order a test, it's just not putting it in the analyzer and giving the results. No, before that there are so many steps. Okay, you can see before we put the sample into the analytical phase, there's a big phase, it's pre-analytical. Okay, the research study says the errors in the result, 62 to 76% happen in the pre-analytical phase, and you can check the post-analytical phase after the analyzer give the result. When the MLT transfer the results, there are errors can happen. That post-analytical phase is 18 to 30%. So analytical phase is only around 10%, isn't it? See, when we issue a wrong results, you just dance like, oh, the laboratory gave a wrong result. I accept there are mistakes happens with the laboratory side as well, but before that we have to check whether the pre-analytical phase is correctly followed. Okay, the problem of the pre-analytical phase is very difficult to control because you can see it happening in many hand. Okay, in the analytical phase, if there's a wrong result produced, I can catch the MLT who ran the test on the same day. Okay, but this phase, lot of people involves. Okay, so these are the main areas in my little experience I have seen. There is can happen in patient identification, preparation, wrong containers, so many cases. Okay, incorrect volume, specimen transport. Let's discuss a very simple case. Okay, very silly simple case. A 40-year-old male presented with an acute febrile illness. Okay, past medical history unremarkable, family history unremarkable. So the routine blood tests were ordered. Okay, and what it is, it's very simple, isn't it? So, what do you think? When you just see this, what do you think? Like before you see the result, if our MLT see this result, he will catch it immediately. What's the problem? Yes, simply. Okay, so it's obviously a hemolysis. Like you can see the AST is also high, phosphate is also high. Both are the parameters in addition to potassium which can increase with the hemolyzed sample. Okay, so this is the circular given by, it's a poster given by MRI recently to be discussed in each and every institution about how to minimize the sample hemolysis. Okay, and they have found what are the most common problems that make this hemolysis happen more often. Blood collection from a small vein. Okay, so they suggest, I know nursing officers are very much experienced than me, and you know what is the good vein. But still, if you happen to collect it from a small vein, there's a high chance of getting a hemolyzed sample using a small bore needle. I know you all are using a correct needle. I know that 21G to 22G for adult and children for 23G. I know that. I know that. But still, if you get a hemolyzed sample, this could check with the needle size and sample contamination with alcohol antiseptic solutions. So they recommend to leave some time to dry the alcohol swab, just to ever make the alcohol to evaporate, and vigorous withdrawal of blood from veins, forceful transfer of the blood. Okay, and underfilling of the tube that contain additives, shaking sample vigorously, inadequate mixing, delayed separation, and even refrigeration without separation. Like if you plan to send it later and you just put it in the refrigerator, all can cause hemolysis. I'll circulate this poster because MRI people, they have asked us to do so. Okay, so these are the ways which makes the hemolysis, and what are the ways to minimize that. Okay, and house officers, you know that because in your medical school they have taught you the effects of hemolysis, but I'm just reminding you again. Okay, potassium, AST, magnesium, LDH, phosphate, they will go up, and bilirubin come down, and serum protein electrophoresis, if you order, like we are not doing serum protein electrophoresis here, but you have a very important patient and you want to send it to medical, and you collect a hemolyzed sample and you send it there, and the consultant see an addition band and he confused his brain. Oh, what happened? What is the reason for that band? So the reason is here in the hemolyzed part. Okay, so please be careful to not to produce hemolyzed sample.